Memorial Health System Speaker Series Online is brought to you by Mission Home Health. Mission Home Health and Hospice is committed to taking care of people by providing the highest quality, cost-effective care wherever the patient calls home. With over 14 locations, Mission delivers skilled home health, hospice, and palliative care services to more than 3,000 patients a day. As a preferred partner with several health systems, Mission works with providers to customize each partnership to provide exceptional coordinated care. Visit our website to learn more at www.homewithmission.com. We take care of people, and one call does it all.
Good evening. I'm Dr. Chuck Pankratz. I'm the Medical Director for Palliative Care Services here at Community Memorial Health Systems. Tonight's topic will be discussing palliative care, current concepts, and what's on the horizon. I am fortunate tonight to be joined by my colleague, Dr. Christina Matz, who is the team physician for the Outpatient Palliative Care Clinic, Ventura Care Partners. Tonight's topic will focus primarily on what the palliative care field is doing in your local community. Palliative care has been a specialty for approximately 16 years. In that time, we've seen a tremendous growth, starting as an inpatient service primarily, and as it's matured, we're able to branch out into the community and provide palliative care services in our clinic. Let's go with the first slide. I think one of the important things is just talk about some key points. They will not be emphasized in the same amount, but they are all important concepts that are involved in the field of palliative care. And we will discuss a distinction between hospice and palliative care. We want to speak to you, the community, about palliative care emphasizing symptom management to enhance comfort, quality of life regardless of the stage of disease. It is a multidisciplinary team. No one person, even myself, who's been in the field for almost 20 years, can do it alone. We focus a lot on advanced care planning, and we do discuss end-of-life care options in patients who sometimes are not at the end of life. Palliative care, you know you've made it when Medicare has a definition for you. And I want to just highlight the bold print that is patient and family-centered care that optimizes quality of life. And it's important to understand in a complex healthcare community that quality of life is determined by the patients and the family, not by the physician and other members of the healthcare community. Palliative care is available throughout the continuum of illness. I'm a middle-aged man. For me, palliative care, if I presented with a heart attack, is to have the full complement of medical treatment because the impact of my illness not only affects me, but affects my family. So, what is the difference between hospice and palliative care? The primary difference is the population of patients for whom the service is provided. Palliative care encompasses the whole pie and talks about quality of life regardless of stage of disease. Well, within that pie is a wedge of patients for whom all the healthcare resources are devoted to end-of-life care. These patients often have a clinical prognosis of 6 months or less, and with that, they're able to take advantage of services which are often not available in their home if they are in an earlier stage of their illness. Why is it important? It improves patient quality of life and survival. It improves family satisfaction and well-being, reduces resource utilization and cost in patients with advanced disease or multiple comorbidities for which the prognosis for survival may be less than 1 year. An important corollary to this statement is that these costs and utilizations are determined by the patient and family's decision making. And this is a difference between a lot of other ways that the healthcare community is a steward of resources, and that our goal is to make sure that whatever decision a patient and family make about medical treatment, it's based on their values and their expectations for treatment. It does involve proactive symptom management and increase attention to care planning, therapy services, nutrition, and social service support to improve the functional status of patients for whom curative or life-prolonging therapy is available. As you can see from this slide, the focus of healthcare for many years was on number one, and what were the outcomes and success or failures of disease management. Palliative care seeks to encompass all of those parameters in order to get a more holistic and comprehensive approach to medical treatment. Yes, unless you've been devoid of a cell phone or surfing the web, you realize that we're all living longer. And while living longer is an admirable goal and one that we all seek, we want to try to also live well. And living well is something that palliative care focuses on through our multidisciplinary approach. So how do we discuss the decision-making in advanced illness? It could also be a plural, illnesses, because many patients, particularly as life goes on, acquire not one, but several medical illnesses, all of which impact their quality of life and ultimately their survival. We try to outline realistic and attainable goals of treatment because most patients with chronic illness want symptom relief. We prepare the patient for the reality of dependency on the support of others. And this includes family members for whom the patient wishes to involve in their care. We assess for financial resources to provide long-term care. We identify eligibility for assisted care through insurance plans, government programs, and local community agencies. What are the benefits of palliative care from a patient perspective? What can a patient and family expect when they receive palliative care services? Comprehensive symptom management that focus on the multiple distresses experienced with illness, coordinated team care to transition patient to changes in level of medical and custodial care. We want to help the family and the patient prepare for transfer home or to a long-term care environment. Psychosocial and spiritual support for transitional events. For most of us, it's very difficult if we develop a illness which limits our ability to function and live in our home in a familiar environment. So for many times in the field of palliative medicine, we are working through our social workers, our physicians, our nurses, and your case manager if you're in the hospital to try to figure out how best to make these transitions successful. What are the benefits to the healthcare system? We all rely on the healthcare system in our community and therefore speak of improved patient adherence to the medical plan through patient and family education, reassessment in the home or long-term care environment, improved coordination of care. A reduction in repeat ER visits and hospital admissions are desirable both by the family, the patient, and the healthcare system. An earlier transition to hospice care when appropriate. Most studies point that when families and practitioners are surveyed, they find that they would have elected the hospice benefit earlier in situations where appropriate. It improves communication of final wishes and helps to interpret advanced directives, living wills, and a do not resuscitate order. Again, it's important that we make the most for those patients who may have 6 months of survival, how to help them live as long and as well as possible. In the field of palliative medicine, while we do value, as any other practitioner, the opportunity to treat medical disease, we also know that it's just as important to focus on basic life functions, such as mobility, eating, and being able to function within our home. An example of palliative care integrating with your treatment plan is the integration of palliative care into the oncology practice. I'll say it now as a palliative care practitioner that not all oncology patients need a palliative team consultation. By and large, our oncologists are very good at touching on many of the principles that we touch on in our field. But there is times where a referral to a palliative care team should occur when psychosocial or symptom issues limit the patient's participation in oncologic treatment. This runs counter to some of the expectations when somebody is offered a palliative care consult, in that we are not there to advise against treatment. We are there first and foremost to advise on how to succeed with treatment, and only in circumstances in consultation with your doctor would we feel that we would discuss end-of-life care. And as you can see, there's quite the overlap between oncologists and palliative care specialists. The difference is that we have often an integrated system that allows for us to have this conversation in one clinic visit with a social worker to speak of long-term care planning and psychosocial support, a chaplain to address any spiritual distress, a nurse to coordinate any medical management when the patient receives home health services, and your physician who is working with your doctors to coordinate the care plan. It's important that the model to which Dr. Matz will be speaking about is that outpatient services of palliative medicine is really where the future of palliative medicine lies. We have a very limited population within a hospital, but we have hundreds of thousands of people in a community. And as you can see, the success lies in the ability to communicate and integrate our services with other modalities of medical treatment and healthcare support. And with that, I will take questions, and please submit them, and we will be continuing with the presentation once your questions have been addressed. Thank you. Our first question tonight is palliative care available for children? It can be, but generally in the field of palliative medicine, most palliative care for children is done at specialty centers where they deal primarily with child-related illnesses, particularly malignancies. That being said, in coordination with a pediatrician or a pediatric oncologist, most palliative care physicians have some experience in the issues which are unique to children. But yes, it is available in our community and also available in specialty centers. No. The question asked is, will I have a new doctor if I use palliative care? Palliative care is meant to integrate and help coordinate the clinical advice and treatment provided by the referring physician. So if it is your family medicine doctor, your oncologist, your cardiologist, your nephrologist, we don't intend to take over the care of the patient or interfere with the relationship that you have with your doctor. We will provide our consultation, and if you or your doctor feel that you need to follow up with us again, then that doctor can make that referral to us. An excellent third question is, what kinds of symptoms does a palliative care team treat? In the eyes of Medicare, one of the most important things that we treat is pain. And for a palliative care physician, physical pain is only one type of pain that we address within our multidisciplinary approach. Pain can have many manifestations: spiritual pain, psychosocial pain, and of course somatic pain or physical pain, which often is the most tangible way that people express discomfort. We also deal with shortness of breath, a common symptom when patients have a respiratory disease or pulmonary involvement with cancer. Nausea and vomiting is a common symptom and is addressed by the palliative care team in coordination with the treating physicians. Anxiety. Anxiety is not just about treating with medications to calm the nerves of the patient. It's also about providing reassurance to the patient, which is a treatment that is best provided by a multidisciplinary team. the list goes on, but those are some common symptoms. Next question, can I pursue active treatment of my disease if I do palliative care? The answer is yes. The intent of palliative care for those that seek disease-modifying or curative treatment is to improve their compliance and successful outcome with treatment. Only within the scope of hospice, if somebody believes that they are better served with symptom management and support in their home, do they forego any active treatment. And our next question, are palliative care services covered by insurance? I'm going to shortly answer the question to say yes, that most insurances provide palliative care services as part of any other specialty service, but the specifics I'll leave to my colleague, Dr. Christina Matz. Christina?
Thank you. Yes. So, absolutely, most insurances cover palliative care. Medicare and Medi-Cal in particular do not require an authorization or even a referral. Mm-hmm. There are some insurance agencies that we may need to have a prior authorization for, but in general it's not difficult to get that. And so absolutely, I think if there's any question, we can always reach out on the patient's behalf and make sure that the service is covered, but typically uniformly it is.
Thank you.
Yeah. Good. Well, so I think this kind of segues nicely into my part of the presentation. As Dr. Pankratz mentioned, my name is Christina Matz. I am one of the team physicians, and I'm primarily based in the outpatient palliative care clinic. And so that is what I'm going to talk to you about today. So as Dr. Pankratz mentioned, our outpatient clinic is affiliated with Community Memorial Health System, and our actual name that you will find is Ventura Care Partners. There are a couple different models of outpatient palliative care, and I'm going to touch on them for a second. There's a home-based palliative care model that really falls under the home health umbrella, and so patients primarily are homebound, and they really have to have a home health need. This is historically more of a nursing-driven program, but certainly things are changing within the community, and we are finding more and more home-based palliative care programs that are physician-led now. In our clinic, we are really a medical consult clinic. So think of it as if you're going to your cardiologist or your kidney doctor, and you're going to come for specialty care. That's really what we're aiming to provide. So this is outside of the primary palliative care or the palliative care that your oncologist may be doing. And so you have to be well enough to come into the clinic. There are a couple different models. There's a freestanding clinic, which we happen to be. There's also clinics that are embedded within a specialty. So for instance, some palliative care clinics are embedded within a cancer center. So as I said, we are freestanding. We are actually right across the street from Community Memorial Hospital in the Medical Arts Plaza. We are fortunate enough to have a true multidisciplinary team where not only do you have myself, but you also have a social worker who specializes in palliative care, a nurse, we have medical assistants, and then also access to a spiritual care counselor. So as Dr. Pankratz alluded to, we're really addressing multiple domains and symptoms to really provide a comprehensive care. Who qualifies for palliative care, or who's right for palliative care? Any patient really with a serious or progressive illness may be appropriate for palliative care. Some of our patients include cancer patients, patients who have heart failure, patients who have dementia or Parkinson's disease, and then patients who have kidney failure. So either their kidney function is worsening and they're contemplating whether dialysis might be right for them, or patients who have already started dialysis and wonder if they want to continue with treatment. And then also patients who have progressive lung disease, so for instance, patients who have COPD or maybe interstitial lung disease like pulmonary fibrosis. How can we help? Well, Dr. Pankratz mentioned this in his talk as well. Really, the goal is relief from pain and other distressing symptoms. We're trying to help clarify goals of care in patients with serious illness, similar to what you would find in an inpatient setting, but a little bit more relaxed, a little bit easier going in the outpatient setting most of the time. We try and enhance communication between patients, families, and their medical team because we realize that a lot of patients see multiple specialists, and it can become quite daunting to have that care coordinated and make sure that there's a lot of, that there is crosstalk and everyone's on the same page, and we're really meeting the patients and families' needs. And so we bridge the gap, so to speak. We assist patients and families with decision making, as well as completion of advanced care planning documents. And then we provide that emotional, social, and spiritual support depending upon the need. Most of the symptom management that I do in the office is primarily cancer-related pain, but certainly treating shortness of breath, some of the gastrointestinal symptoms like Dr. Pankratz alluded to, nausea, vomiting, constipation, as well as anxiety and depression. Advanced care planning, we assist patients in completion of advanced directives, which much of the community is familiar with. It might be part of your living trust or your living will. But we also assist patients with completing PULSE forms. And PULSE is an acronym for Physician's Order for Life-Sustaining Treatment. And it's a form that was designed with emergency medical services to really, if there was an incident in the home, 911 was called and the paramedics came out, they would use this form really outside of an advanced directive to guide the treatment that a patient would want. Caregiver resources, I would say caregiver and patient resources. We are well equipped to provide resources for patients and their families. We partner with other community-based programs like the Coastal Cities Cancer Resource Center, the Better Breathers Club. So our palliative care social worker is really well adapted at linking patients with community services. And then coordination of care, as I discussed earlier. So I was asked to talk just briefly about the impact of COVID-19, the pandemic, and how it really interfaced with palliative care. And, I think just giving a little bit of background about myself, in my previous life, I was an emergency medicine physician, and I spent a decade in the emergency department taking care of patients with serious illness. And I learned pretty early on in my career that there was such a need for upstream goals of care discussion and advanced care planning, because I would take care of patients on a daily basis who found themselves in an emergency situation, a crisis situation, and were really forced into making decisions about their health care that was almost impossible to do because it was just too difficult to really know what the right decisions were for them at that time. And so, I think that was part of what led me into transitioning into palliative care. So fast forward into the COVID-19 pandemic, and I think what we found ourselves in is, the entire healthcare system was almost like an emergency medicine experience, in that it was really a crisis mode. And I think it highlighted the need for providers. I think it was twofold. There was the provider side, where it highlighted the need for more training for medical providers to discuss, to be adept at discussing serious illness. And then I think on the patient and family side, it really brought about the need for upstream goals of care discussion, upstream advanced care planning, so that we make sure that we're really focusing on truly patient-centered care. It's not one-stop shopping. We really are defining what's important to patients, defining what quality of life means to them, because certainly it's different for everyone, getting that down on paper, talking with your family about what you've written down, and then documenting it in your advance directive. I think the other piece of the pandemic was that it did mainstream telehealth and healthcare for the first time. Telehealth has been used for patients who live in rural communities for a while, but it really is mainstream, the idea of delivering care and easier access to care for patients with telehealth.
Sure.
Yeah. So how do you access this? I think this is kind of where we started. So palliative care is covered under almost all insurances. Again, no referral is needed if you're Medicare or you have Medi-Cal. We have patients who self-refer if they feel that there's really a need. If a prior authorization is needed, we'll assist patients with getting that. And then certainly if you have any questions about whether palliative care might be right for you or your family member, you can always call and we'll be happy to explain services again, go over things we can offer, how we might be able to help.
Great.
Okay, I think we're ready for our second question and answer period. Will I become addicted to pain medications if I receive palliative care treatment? Well, I think this is a little bit of a tricky question, and one that I hear often. With the opioid epidemic, there's been a lot of media coverage, and patients will come, and that's one of their first questions. What if I take the pain medication? What will happen? I think that certainly patients who are given medications like opioids will develop a physiologic tolerance to the medication. So that means with time their body will adapt, and they may need a higher dose. But when we're talking about addiction, we're really talking about the kind of the psychological aspects of using the medication inappropriately, using the medication for the wrong reason, etc. And I don't find that to be the case most of the time.
I would add to that, Christina, that most of the patients with a history of addiction preceded palliative care management. And the basic philosophy of palliative care is not to rely exclusively on medications to relieve pain. There are other non-addictive ways to deal with pain over the course of weeks or months that we integrate into our practice. Yes, we are mindful of the potential for addiction. We certainly have a population that has serious pain issues, particularly our cancer patients. But we are also mindful not to simply rely on those medications as the way to keep somebody comfortable and functional.
Absolutely. And pain medication is often not the first thing that we would actually prescribe.
No.
Yeah. So.
Excellent question. Thank you.
Good. Okay, so question number 2. How do I know if I need palliative care versus hospice? Well, as Dr. Pankratz talked a little bit about, hospice is really reserved for patients who have a prognosis of 6 months or less. And typically, when I'm talking to my patients who are considering transition to hospice, I think it's really important to think about, what are your goals? What are you hoping to achieve? And, if your goal is that you don't want any aggressive life-sustaining treatments, that you're not interested in going back to the hospital or, having further treatment for whatever your serious illness is, that even if we're a little uncertain about what your prognosis might be, that often might be the time to consider the transition.
There's so many ways to define this excellent question. And there are several functional statements that I often provide to the patient. One is if others have to help them live their life more than they can help themselves, if they have any life-limiting illness, that may be a time to talk with a palliative care specialist or their treating physician and ask about the option of hospice. Hospice is really meant to be a very flexible benefit, one where an individual can go on hospice. If they change their mind, they can revoke it. Everybody who is interested in hospice can have a hospice evaluation without any coercion to sign on to the benefit. So it is actually should be an easy question, though a difficult path to arrive at the question. The question itself should be answered in a way that allows the patient to choose their options.
Is palliative care available for chronic pain issues? Well, I think if the patient has a serious illness or life-limiting illness that is also kind of intertwined with chronic pain, then certainly it may be appropriate. But when you think about palliative care, we do a lot of pain and symptom management, but we also are looking to treat all aspects, of potential distress, not just the pain in itself. So I think it kind of varies on a case-by-case basis.
Sure, I think there are some highly qualified pain specialists in the community, but if we will not say no to a case as much as we will apply the principle of a multidisciplinary team. And if we feel that a multidisciplinary team can play a role in the management of the patient's symptoms, and it often is easier or more conducive if they have a life-limiting illness, and then we certainly can get involved with chronic pain.
Yeah. Okay. Next question. Is there a long wait to get an appointment in the clinic? Well, it's typically about 3 weeks, but it can be sooner. There's a little bit of variability there. If a patient calls or to make an appointment, or if there's a referral that's sent to us from another provider, our palliative care social worker will reach out to the patient or family, do an assessment on the phone, see what the need is. And so certainly if there is a more urgent need, then we will expedite the appointment and try and get you in sooner than that 3-week turnaround. Yeah.
Want to take that question?
Sure, yeah. Our service is available for Spanish-speaking patients. Well, we are fortunate to have 2 certified Spanish interpreters in our clinic. They do a fantastic job. I think we really provide good care for our Spanish-speaking patients, and so absolutely, yeah.
Yes.
And there's even someone, should you call, there's someone who answers the phone and they speak Spanish and they can describe the services to you. So absolutely.
Yes, as the person charged with future planning, particularly the outpatient palliative care clinic, we insisted that new hired staff be bilingual. And so beyond just having hearsay with bilingual staff, it's an absolute necessity in our community, and we can assure any Spanish-speaking patients that we will provide them the necessary translations so that they could have a meaningful encounter with us.
Okay. Do members of the palliative care team have special training? Yes, absolutely, they do. The physician, obviously, I've done a palliative care fellowship, but even down to our social worker, they have specialty palliative care training. Our spiritual care counselor also has specialty palliative care training. So you're really amongst a team that is well versed in palliative care and can provide you with really excellent support.
Mm.
Yeah. Let's see. Is there ever anyone who would not qualify for palliative care? Well, we review every referral that we receive. I think if it was primarily a chronic pain issue in a patient who didn't have a serious or life-limiting illness, that may be a patient that is not quite right for our clinic. But again, it's on a case-by-case basis. So I wouldn't make a blanket statement that said absolutely there's X person who wouldn't qualify.
Our experience with the insurers is that we have never had a palliative care referral denied. We do try to make sure to not obligate the patient or the family to have an extra consultation, when their time is very important, and it takes an extraordinary effort to follow up with a new consulting physician or team.
Yeah. Let's see, should I include palliative care in my advanced care planning? I'm not quite sure. Do you? I'm not quite sure what's meant by that. Do you?
Yes. I would answer it as the following. If you were to put the words into a document with advanced care planning, you can always specify to your family or to your counsel that if there's any questions about decisions regarding my treatment, I request a palliative care evaluation.
Good, thank you. Thanks for your help on that one.
Sure.
Is there a time limit on how long I can receive palliative care? Absolutely not. I have patients who I've been following for almost 3 years, which is about the time I started, I believe. So absolutely not. There's no expiration date. We will help support you for as long as you need the support.
I'm going to answer this question. Will the same nurse be caring for me, my loved one, at each visit? For our standalone clinic, the answer is yes. We provide consistent staff in order to make sure that they are able to develop a quality therapeutic relationship with the palliative care team. But just to expand on that question, as Dr. Matz outlined, some palliative care is defined by home health services. And each home health service has different policies as to whether they have the same nurse address the issues of palliation in the home. But for our clinic, yes.
Thank you. Okay, I think we may be getting down to the last question here. In your clinic, is there an on-call provider? Yes, we're actually fortunate enough to have 24/7 coverage for phone calls that may come in after hours or on the weekend. Dr. Pankratz and I have a third partner, Dr. Scabetta, and we rotate taking phone calls for patients who may need direction or assistance. So absolutely.
Yes.
Yeah. Okay, well, we just want to thank you guys for joining us tonight and wanting to learn more about palliative care and the services we offer and Community Memorial Health System. And certainly if you'd like more information, you can find us on the CMH webpage. And I think that's a wrap.
Thank you, everybody.